This is a series of two cases of intumescent cataract where spiral Rhexis technique is used. I always use cystitome attached to visco syringe. Thereby, whenever anterior chamber becomes shallow, I inject visco without removing cystitome out of the eye. I made a small nick in anterior capsule and raised it immediately to make a flap and continued with 2 to 3 mm diameter Rhexis. Now I am going around the Rhexis margin to make a spiral Rhexis. I always intend to make the flap folded on the anterior capsule, which eases the Rhexis making step. As I am unsuccessful in continuing Rhexis with cystitome, I come out, inject viscoelastics and continued Rhexis with McPherson's forceps. Now the Rhexis flap is like ribbon and long, trying to come out of the main wound. At this point, we'll cut the flap to make it short. This avoids extension of Rhexis subincisionally. At this point, I would like to complete almost 180-degree Rhexis in one go to prevent Rhexis extension to periphery. At this point, if Rhexis flap comes out of the main wound, then also there is little chance of extension of Rhexis to periphery. I cut the Rhexis flap again and continue the spiral Rhexis to get an adequate size. Here, I am having difficulty in holding Rhexis flap because the angulation at the base of McPherson's forceps is being obstructed at the main wound. Micro Rhexis forceps would have been helpful. With repeated attempts, I was able to catch flap and complete Rhexis. Every case of intumescent cataract is different. In both these cases, I have used only HPMC viscoelastics. In previous case, there was no much liquefied cortex. In this case, the moment I make the nick, liquefied cortex escapes out of the capsular bag. I did press the nucleus down through the nick with cystitome to make more liquid cortex to escape. Now, I am having difficulty to raise flap. If I continue, I will have Rhexis extension. So, I went to another angle and was successful.